Hey, good evening, everyone. Thank you very much for sharing your time with me, and welcome to this sharing of information, if you will. I don't consider myself a lecturer, although I've done over 500 of them. I just share clinical experience. So I'm a full-time practicing dentist. I own several practices in St. Louis, Missouri, and so I'm just here to share a little bit of stuff with you. So again, we're talking about everyday clinical dentistry and getting the most out of zirconia. So the problem with zirconia is it's not a perfect material. There is no such thing as a perfect material. It's a wonderful material if used correctly. And if the dentist, you and me, if we do our job within certain parameters, then it's a very successful material. And what you see on the screen there, of course, those are dramatic cases, but you've seen them all. All of you have, if you've been practicing more than 5 minutes. You've seen zirconia crowns, like the top one, break right down the middle, probably. And then you've seen marginal ridges chip off if you layer it. Bridges, zirconia bridges, we have been rethinking zirconia bridges on when the best time to use them is, what the best indications to use them are, and what we can do to prevent the ultimate failure. And that's what you see on the right there. And that's that tooth that's cracked in half. That tooth had a porcelain inlay, believe it or not. So anyway, I'm here to share the experience with you. First of all, I want to start out by saying that if you came here for perfection, you came to the wrong place. I'm just going to share with you what we've learned clinically, blend it with a little bit of science and some research, and try not to put you to sleep. So anyway, that's my goal for tonight. So first of all, we can't do these courses without sponsors and help. And Viva Learning is an awesome way to get a lot of your CE online, especially in today's climate with COVID-19 and all. Viva already had a system in place so that we could do a lot of this remotely. So I appreciate that. And Bisco's our sponsor tonight. Bisco's a company I've worked with for most all of my practice career. And as you can see with my picture on the lower left, I didn't start practicing last year. So I've unfortunately been around for a while. Hey, anyway, so let's start out with the basics, and that is real clinical stuff. What issues do you have with zirconia restorations? You know, it's funny, I've had quite a few associates over the years. And just recently we hired a couple of associates, and both of them, one of them had quite a few years experience and the other one had a couple years of experience. And it's funny that when we hired them, they both preferred Emax over zirconia. And so I always ask, well, why is that? And it's because of breakage or failure in some way. So my question to you is what issues do you have with zirconia restorations? We all have the same ones. We've all seen them debond or the cement fail. We've seen the restorations fracture, like some of the ones I showed you on the earlier screen. The third one, it comes up once in a while, and that is if you tried to remove one. Trying to grind through zirconia is a brutal task. You have sparks flying all over the place. You got things catching on fire in the operatory. It's like a fireworks show. So, and then what burrs do you remove them with? You know, it's just hard to remove. So that's an issue. And then number 4, it says opacity, but not just opacity. It's, a lot of zirconia is really ugly, to be honest with you. Yeah, it's a replacement for a lot of materials that we use in the posterior, but how about in the anterior? We'll go over that a little bit tonight. So the goal for tonight is how to use zirconia more successfully, get better clinical outcomes, if you will. And here's your course description, but the objectives, zirconia failures and how to prevent them. Let's go over what goes wrong and where the real blame is. Number 2, simple regenerative resin cementation. In other words, if you're going to do zirconia crowns in the posterior, and most of us do 1 and 2 units at a time, that's the bread and butter of restorative dentistry. So if we're going to do 1 and 2 units at a time, what's your everyday cement? What do you do every day? Normal situations. Are there cements that are easy to use, almost no sensitivity, and long lasting? So yeah, that's what we'll talk about, everyday cementation. Number 3, What about those other times when you really need maximum adhesion? What's the best way to bond to zirconia? You know, it's funny too, is over the years with associates that I've had, um, and some dentists don't think you can bond to zirconia. And you know what? There's still a lot of dentists who think you can't. So I'm not here necessarily to change anyone's mind. I'm just here to share the experience and a little bit of research, like I said. And let's start out by just saying, I really appreciate your time and your dedication to learning. Hey, look, we all have learned some things with the coronavirus. Let me tell you one thing we've definitely learned, and that is to appreciate every day that we have, every healthy day that we have. Appreciate, you know, what life has given us, and don't take it for granted. Use all the time that you have, use it wisely. Don't be bitter, don't complain. We do a little bit, but look at things a little different. I mean, something so small like a virus made such a big change in our world around us. And, you know, it's still going on. So I just want to make sure, first of all, that I hope the best for you and those you love and peace in your life. No matter what, dentistry is second to our personal happiness and our fulfillment. Now, that said, we were called to be a dentist. We were called to serve patients. The better we do at that, the more success we have clinically, the happier we can be personally, honestly. So if we struggle in the office with different situations, it rubs over into our personal life. You all know that. No matter what career you have, if things aren't working out at home or at the office, you know, it kind of rubs off on each other. So what I'm saying is that it's a whole package. Thank you for giving me the most precious gift that you have to give, and that's your time. And 2020 has been quite a year, and I'm going to go over some reasons that it has been a very memorable year beyond the virus, of course. Hey, let's go over a little bit of research, a little bit of numbers first. I'm not going to bore you with charts and graphs and all that junk, but let me just go over some stuff with you clinically. There's 3 basic groups of zirconia. First of all, you can take a zirconia crown and you can layer it with porcelain, or you can do zirconia without layering, and that's monolithic zirconia. 3 basic groups of restorative zirconia, whether it's monolithic or layered. Number 1 is anterior zirconia. Number 2 is posterior zirconia. And number 3 is a blended zirconia. What do we mean by those? Anterior zirconia is more translucent. It looks better. It's less opaque and ugly. You know, the first zirconia crowns, like Bruxer and some of the other zirconia materials years ago, they were just, they were tooth colored, but they were still kind of there was an ugliness to them because of the opacity. So anterior zirconia is more translucent, but it has less fracture resistance. So it's more likely to break. How do you cement those? How do you put those in? How do you prep those? That's what we'll talk about. And number 2, posterior zirconia. That's your normal old posterior zirconia. It has more opacity, more strength, more durability than anterior zirconia. However, if cemented correctly, they both are very, very close to some of the best materials we've ever seen in dentistry, aesthetically speaking. And then the third one on this list is blended zirconia. That's a fairly new approach, and that is that we can have a zirconia restoration that's opaque in the gingival half or so, and more transparent, translucent in the occlusal half. So you can have a blend of posterior and anterior zirconia in one restoration. And so we'll go over that a little bit. So from the research, here's some numbers for you. You know, zirconia has been studied so much over the years. We all have the same questions with zirconia. Number 1, what's the best preparation for it? Number 2, can you bond to it? And if so, how? And number 3 really is, how do you adjust them and polish them? Those are all really important, and we'll kind of go over those just a little bit. But here's the deal. I showed you some fractures. Here's another fracture on the bottom of this screen. So it's been studied a lot over the years. And I say another one, if you wanted to, if dentists ask questions, is does it wear the opposing? So let's go over that. First of all, with the research, number 1, 88% of crowns survived after 5 years. Well, let's reverse that. That means 12% or so, a little less than 12%, didn't. That's not very good. If we're charging patients $1,000 for a restoration and it's only lasting 5 years or less, I don't think that's a good return on investment for the patient. So we've got to get that number better. We'll talk about that. Number two, 12.5% of zirconia crowns came out within 5 years when cemented with a conventional cement. You know, like zinc phosphate. Nobody uses zinc phosphate, of course, but how about a regular glass ionomer or a resin modified glass ionomer? Well over 10% failed within 5 years when using a traditional cement. Therefore, we do not use traditional cements, no glass ionomers, no resin modified glass ionomers with zirconia crowns. Again, you can argue with me on that. I'm not here to change your mind necessarily, but to show you what the research and everything goes with. We want to use a little adhesion, and I'll talk to you about that. Number three, 6.6% loosened with a self-adhesive resin cement without something in the cement that bonded to the zirconia. Yeah, of course, that's the scope of the lecture. Is it always the cement that fails? Is that the problem really with zirconia? I'm going to tell you that it's not. So no matter what materials are out there, and like I said, Biscos are one of our sponsors, and I think they make the best materials on the planet. However, it still comes down to you and me. Often the problem with a crown fracturing is, I don't care what cement this dentist used in this picture, it's you and me, the preparation. So after you prep and send it to the lab and you have the patient come back and you cement the crown and then you adjust it a little bit maybe or whatever, and you find that on this picture that the zirconia itself is only about 0.5 millimeter, maybe a little bit more thick. Now you see cement on top of that. It doesn't matter what the cement was. It was doomed to fail because of us. So the preparation, the adjustment, and all that. I will tell you this also, is that some of my background, doing a little bit of studying on this material, we often see the fracture start in zirconia where you and I adjusted it. So keep that in mind. When we adjust zirconia, we want to use light pressure, high speed, water, a concentric turbine, and then polish it well afterwards. Better yet, don't use a coarse diamond on zirconia because those scratches are hard to polish out, and often the fractures start where those coarse diamond scratches were. So we use a fine diamond, light pressure, water, a concentric turbine just to make sure our burr isn't like slamming into the zirconia, and then polish well. Yeah, things break, you know. So we told our dog Bentley, you're going to get to know him a little bit tonight. We told Bentley that he was getting fixed. And he said, well, what? I'm not broken. So now if you've had a dog and they've had surgery and all that stuff, they get the cone of shame. So this is the cone of shame on Bentley. And he's like, my gosh, I wasn't broken. Why did you fix me? So again, talking about broken restorations, there's lots of opinions. There's lots of research. When you look at the research and all, what you'll see going back over 10 years with zirconia is that how we prep matters almost more than anything. How many units we do in a bridge, and then how we cement and how we handle the zirconia. So there's lots of stuff on that. So if we were to summarize a lot of the research, and if you've seen any of my other webinars, you'll see some more research on that kind of stuff. But if we were to summarize a lot of the preponderance of evidence these days from research, number one, if the prep's good, almost any cement works. So if your preps are exceptional, then you can cement it with, heck, Elmer's glue if you want, almost. Number two, self-adhesive resin cements had significantly more success than traditional cements. Therefore, we do not cement zirconia anymore with a traditional cement. We always use one that's a self-adhesive dual cure resin that has something in it to bond to the zirconia. I'm talking a chemical bond. Number three, poor retention preps or high occlusal stresses, those contribute to failure more. Adhesion with resin bonding is required if the preparation's poor or high occlusal stresses. Resin bonding is required and not an option for clinical success. Number four, proper resin bonding is more critical for high translucency zirconia. Like I said, the anterior zirconias look better, they're more translucent, but they need more support. And I'm talking long-term support. So that is a resin that won't wash out and something that adds strength to the zirconia by chemically bonding to it, and then also bonding to the tooth. So again, there's two interfaces between the cement and the crown, and another interface between the cement and the tooth. Number 5, 50 micron aluminum oxide, air abrasion of zirconia before bonding helps. We'll talk about cleaning and preparing the zirconia. There has been a lot of debate on that over the years, how well air abrasion helps with zirconia, but the research shows that it does help. It says 50 micron on that slide, 27 micron also helps as well, but most of the research has been done with 50. Talking about chemical adhesion to zirconia, and again, if you've seen any of my lectures on zirconia adhesion, you've seen the slide before. We're going to do some different cases with it tonight and different approach. Zirconia adhesion is based on MDP. I don't even know what that word is. A great big long word. I had to Google that, and Siri told me it was this thing. But 10-MDP is a chemical that allows for chemical bonds to zirconia. I'm going to stress that. Yes, no matter what my associates have told me, we do get a chemical bond to zirconia. It depends upon the MDP and how we prepare the surface of zirconia. MDP. There's different places you can get MDP. MDP has been around for quite some time now, and it comes in different materials. For instance, on the left, there's a zirconia primer that's based on MDP, that's Z prime plus. The back two bottles together say universal primer, and those also have, it's a dual cure material that has MDP. All bond universal to me is a gold standard in all bonding materials. We'll go over that later. MDP in there too, and Theracem, which is a self-adhesive dual cure resin cement like we talked about a second ago, has MDP in it to bond to your zirconia. It also has the benefit of releasing calcium fluoride. Again, so the point is MDP can come in different products. Bisco has a lot of them, and it's an excellent formula. It's not just the MDP in the materials, it's also the other stuff in there that allows the MDP to work. So all that's really important. So again, a lot of research on that, how they work, why they work, and how you're going to prep the tooth for cementation and how you're going to prep the crown for cementation. Again, debatable over the years. How can air abrasion help? I mean, if you look at the inside of a zirconia crown, that surface just looks like something that you can't bond to. It's a little bit shiny-ish. It's kind of looks like, it doesn't look like frosty etched porcelain. So like with lithium disilicate or Empress or other feldspathic porcelains, we put a little hydrofluoric acid on there, rinse it off after a little bit of time, and then put a little silane on there, and then the surface looks frosty. So it looks frosty. That looks to me like I can grab onto it. It looks like there's some bumps on there that make it frosty that allows me to have like some mechanical retention. Yeah, you can, and that's cool. And with silane, a little bit of chemical retention. With zirconia, though, when we air abrade the surface, it allows for my MDP to work better with the surface. Again, I told you 50 micron aluminum oxide is what most of the research is on. 24 or 27 micron aluminum oxide seems to work well too. Many of you get zirconia crowns back from the lab, and the lab has done the air abrasion for you already. So here's what I'm asking you, is just find out from the lab if they did the air abrasion for you already. And if they did, you're golden. You don't need to repeat that, most likely. And again, if your lab's done it, probably don't need to do that. Well, so let's go back to the basics. You can use a regular cement with zirconia. Like I said, if the prep's great and there's not a lot of occlusal forces, you know, parafunctional habits, grinding, clenching, that kind of worn dentition, few teeth, that kind of thing. If your prep's great and you don't have those situations, then you could probably cement it with anything you want. So bond zirconia on the left there. Why bond? Well, you get better retention. Number two is probably the most important reason these days, and that's stronger restoration itself. So not only did we get it to stick to the tooth better, but we strengthen the restoration as well. Number three, better aesthetics. I put a question mark there because zirconia can be real opaque and the cement won't even influence the final color or anything like that. So bonding, you know, is important. And for instance, if we did veneers, And I have done quite a few cases of zirconia veneers. I just did one just a few weeks ago, again. And I'm not saying there's a big, huge reason to do zirconia veneers, but if you do zirconia veneers or any kind of veneer, you know that your prep is not retentive. So we need to bond those in. So bonding is important. You know that. And on the right side of the screen, why not bond? Why not? Why not just cement all of our crowns, everything we get with a resin modified glass ionomer or a glass ionomer or whatever it is you have, Gorilla Glue. Why not? Well, because we don't strengthen the restoration and we don't get more retention. Why would you use a regular cement? Well, they're easier to clean up, less technique sensitive, and easier to remove. If you've ever cut off a zirconia crown, especially if the color matches well, it's hard sometimes to tell if you're drilling on the crown, the cement, or the tooth. So, you know, and if you hemisection a tooth while you're trying to remove the zirconia crown, of course, you know, then the question becomes, would you charge the patient for the hemisection as well? And then I'm not even going to go there, but, you know, that's something you have to ask yourself. Again, the problem with fracture may not be the material. I want to stress that in the beginning because great bonding cannot overcome a poor prep. If your prep is lousy, expect things to fail. Now, sometimes we don't have a choice. We've got a real short second molar, for instance, with very little clearance, and you prep it, and I swear you only have a couple millimeters of height on your walls, and you know, it's probably a grinder to begin with. How are you going to restore those teeth? So again, if you're going to do those kinds of things, and we all do cases that are compromised, then how are we going to bond to those? So real quickly, before we start going over adhesion and cementation, the ideal prep for zirconia. So whenever we talk about different ways to cement, the prep matters. Preps matter. You and me, what we do still matters. Ideal zirconia prep, 4 to 8 degrees of taper, 4 millimeters or more axial wall height. So we'll just say as much axial wall height as you can get. So don't over reduce. The third one is a 0.5 millimeter to 1 millimeter rounded shoulder or chamfer. Yes, you can do zirconia with a feather edge. My only problem with this, I prefer that the lab not pick my margin for me, and I want a little bit extra bulk at the margin. We've seen some semi-lunar type fractures at margins that are very, very thin. So again, we want to try to prevent that. Thicker is better if we can, you know, without going crazy prepping. Next is occlusal clearance. I know you see it written. I know it's still out there because I just looked it up a couple of days ago. You still see some companies telling you that for a monolithic zirconia crown, 1 millimeter of occlusal reduction is ridiculous, is okay. And I'm just saying that might be ridiculous. It may not. I'm not here to condemn anyone else. I'm just saying that you and I, when we prep, we're not exactly like measuring the difference between a millimeter and 1.5 millimeters. But I'm just going to say that 1.5 millimeters to 2 millimeters gives you a little bit thicker zirconia, especially if you adjust your zirconia crowns, which we don't, or we try not to. Often when we do occlusal adjustments, if we cement a crown that's slightly high, then we're going to probably adjust the opposing. Again, that's philosophy. But 1.5 millimeters to 2 millimeters occlusal clearance is ideal. If you're going to layer it, then we need 2 millimeters occlusal clearance. So again, a little bit more aggressive to layer. Again, if you look at preparations, this is a real tooth. All I did was get rid of all the surrounding stuff. The one on the left is a good preparation, 4 to 8 degrees of taper, 4 millimeters axial wall height. You know, a fairly nice preparation. I mean, it's my prep, so it's not perfect. The middle one, we took down a couple more millimeters. That's overly prepped, I guess. You can't see the opposing. You're not sure there. But just a lot less retention when we over prep. So 1.5, 2 millimeters occlusal clearance, all you need, no more. The one on the right, whenever we have that rounded dome effect, it's real hard to get things to stick to that. So all I'm saying is the most important criteria and success for all of us is still our dentistry. That's still important. However, the cements matter. They definitely matter. So we're going to break this up into 2 categories. Number 1, everyday excellence. And then the second one is maximum performance. So for everyday crown and bridge, excellent performance, everyday situations, easy to clean up, low sensitivity, a good value also, releases calcium and fluoride. Theracem is our go-to material and has been for quite some time. Zirconia, if you have a good prep, and low occlusal stresses. In other words, your normal everyday dentistry kind of thing. You're going to try your restoration in, you're going to clean your restoration, rinse and dry it after you try it in, and then on the tooth, you're going to isolate it, you're going to wipe it with some gauze or something like that. Now, let me stop you right here and just ask you a simple question. If you do a prep, let's say on a lower right molar, and the patient comes back in a week or so, whenever you reschedule the appointment to cement the crown, do you anesthetize whenever you cement a crown? Then some of you do. Some of you anesthetize whenever you take a temporary off and cement a crown. Most of us, though, don't. Most of us pop off the crown, temporary crown, and the assistant tries in the crown, and we come in the room, verify the fit, and cement the crown. Most of us don't numb. In fact, the numbers show us that between 85 and 90% of single unit crowns are cemented without anesthesia, which is exactly how I do it. In fact, it's really rare that I numb someone. And when we would is if they were having sensitivity for whatever reason, preoperatively or with the temporary or whatever. So again, if we're not numbing the patient, that limits our choices on how we're going to treat that tooth or how we're going to bond in our restoration. Because if we don't numb the patient and you were to put, say, phosphoric acid etch on the tooth, on a vital tooth, you would send the patient out of the chair. You'd probably get a bad Google review on that one. If you put a universal bonding agent, we'll talk about All-Bond Universal in a few minutes, a pH 3.2, that acidic of a material on a crown prep that has been prepped into dentin, that lights the patient up. So again, probably not a good Yelp review if you were to do that. So most of us use a self-adhesive dual cure resin cement. I recommend that it's a regenerative type cement that releases calcium and fluoride. That reduces sensitivity, increases longevity, and provides an environment where tissues can heal. Second thing is that your cement needs to have MDP in it. Because again, we just went over that it needs to bond to zirconia to help increase the chances of long-term cement. Okay, well, let's get going on this. For maximum performance, and we'll do most of our cases today with maximum performance, just to show you how we do it, compromised prep or high occlusal stresses. You're going to try in, you're going to clean your restoration, rinse and dry it. Now on the tooth, you're going to clean your tooth just a little bit better. Maybe with pumice or chlorhexidine, whatever it is that you want to do. And then a universal dentin bonding agent like All-Bond U or universal primer from Bisco. And then cement. When we want maximum cementation strength, we want a dual cure resin cement. So again, the bonding agent that is apart from the bonding agent inside a self-adhesive resin cement, when we have a separate bonding agent, that gives you more bond to dentin. So let me say it again. In a self-adhesive dual cure resin cement, there is stuff in there that bonds to dentin. In a regular dual cure resin cement, like Dual-Link, there is not anything in there that bonds to the dentin, and we use a separate bonding agent. The strength of bond to the dentin with a All-Bond Universal is stronger than the bonding material inside a self-adhesive resin cement. I'll clear that up in just a second here. Everyday excellent. All things being equal, if our restorative materials can have a positive influence on the oral environment, shouldn't they? So we try not to be negative, but let's be positive instead. So again, with Theracem, we get an exchange of ions, calcium and fluoride, and that's awesome because that may decrease the amount of bacteria around our margins. It may provide longer lasting margins by changing the pH around there and reducing microbes. And we get that fluoride strengthening of the tooth and dentin. So all good. So that's a bonus. So this also is a very easy to clean up cement. One of the easiest to clean up cements that we've ever tried. I'm lucky I get to test a lot of products, some of them before they hit the market. And of all the cements that we've ever used, this is probably the second easiest to clean up cement that we've ever used. And that is honest truth. You'll know some materials like Multi-Link. That's an awesome material that we used for a long time, very strong, very difficult to clean up. So as an everyday cement, we're constantly leaving cement. There's other cements on the market that give a good bond, but very difficult to work with. Theracem is just easy, 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 contains MDP, no etch, no primer, no bonding. It goes from acidic to basic in just a few minutes, and it's a good release of fluoride and calcium, very important. So in this case, we're going to cement a bicuspid that is a good retentive prep, even though I did it, a low occlusal stress case. We're going to use our Theracem. You can see it oozing out. We have the patient bite slightly on gauze. So the second bicuspid is a monolithic zirconia restoration. I got a little bit of stain on there on the gingival half, but that's monolithic zirconia. Again, beating the looks of that PFM, well, that's kind of an ugly PFM, next door is easy. That's no problem at all. Monolithic zirconia, again, we're starting with the easy stuff first. When we see wear like this, especially in someone in their 20s, this is a 20-something-year-old patient, material choice matters. Again, you could make a claim in this case for using a maximum adhesion. However, in this case, with a decent prep, we are going to cement a monolithic zirconia crown. This is an anterior zirconia that we're going to do on this tooth. Again, 4 to 8 degrees of taper, 4 millimeter axial wall height, 1.5 or so millimeters of occlusal clearance, and then we're ready to go. So the inside of the restoration looks like that. We're going to try it in like we are doing on the right side. We're going to take it out of the mouth. We're going to clean the surface by using a cleaner. We use Zirclean. It's a product that reduces the contaminants on the surface. We'll show you that in a second. And then we're going to cement with Theracem. Very easy. Tissue response is awesome after a few weeks. And because of the kind nature or biofriendly nature of the material, the calcium release, the fluoride release, good tissue response is awesome. 2020, what a year. I have to tell you, it's been a strange year for me. Notice I am watering my plants there, but notice on my arm is a cast. I had an ulnar nerve reposition in my right arm. I had bilateral carpal tunnel syndrome surgery. So that was July 1st of this year. I've had all this stuff going on. And the doctor said I wasn't supposed to get my cast wet. I'm not supposed to lift anything over 5 pounds, which I'm not. I'm just kind of holding the hose there. So I'm playing by the rules. Everyday excellence. So again, we talked about Theracem. There's more to that story. Hold on. Everyday excellence. So here's a case with a bunch of crown and bridge that we did, upper and lower. This young lady has some bonding on the teeth that was done about 22 years ago. I know that because I did it. It looks terrible at this point. That's an old material, by the way, called heliomolar. And I know you don't remember the material. Most of you are too young for that. But heliomolar had I learned that from one of my gurus, Paul Belvedere. But anyway, it worked well. It got too thin on the cuspids. I didn't do a great job, of course, but she had an enamel dysplasia problem. And regardless, let's take a look at this case. Here's her occlusion, decent occlusion, young female. So after the preparations, notice the color of her teeth, a defective type of enamel, if you will, discoloration. I removed the old bonding. She had interproximal decay after this time. And we're showing the lab what color our preparations are. In this case, we're going to use monolithic zirconia restorations. No layering porcelain, just monolithic anterior zirconia. We're going to cement all of those with Theracem. Notice there's high calcium levels in the Theracem, which is what we're going for today. Calcium and fluoride. You know fluoride's great. Calcium is where we're going in the regenerative, bio-friendly, bio-interactive world, if you will. Notice that the material is a little bit whitish, but if the preparation is good and the film thickness is minimal, then we have the color does not influence the final shade of the restorations. So this is a few weeks after cementation. Again, not a perfect case by any means. This is a monolithic material that's a blend. So it has a more opaque zirconia at the gum line, and at the incisal edge, it is a translucent zirconia. And I'll show you the material in just a second. But anyway, upper and lowers, all done at the same time, cemented with Theracem, just showing you that even on more important, comprehensive kind of cases, Theracem is our go-to cement, just incredible. Hey, tomorrow's election day, and the only reason I'm bringing it up, 2020, what a year. I don't know what's going to happen. I don't care what side you're on. I just want the good for the country. It's just wild right now, all the stuff going on. Every human being is important. Every human being, we all have an important role to play in this great big world. And so, again, I just want you to understand that as a dentist, you have a great important role to play, very instrumental in the overall health of our patients. There's a heightened sense of awareness on what dentists can do for a patient's self-esteem and function and everything like that these days. So we're very fortunate to be able to do what we do. But never underestimate the power of a large number of ignorant people. I've got a picture of the Capitol. I don't know, maybe that has nothing to do with it. Everyday excellence, again, let's do another case before we get on to complicated bonding. Monolithic anterior and posterior zirconia. So let's do some anterior zirconia and posterior zirconia in the same case. Here's monolithic zirconia, the cuspid to cuspid. And in the posterior, let's do posterior zirconia. Is there a material that has easy to use, great long-lasting effects, that has MDP to bond to zirconia? Of course there is, you know that. After we try them in, and some of my patients aren't good with my temporaries. Maybe my temporaries are lousy. Maybe I just don't polish enough, or maybe they're just rough look. I don't know, maybe I'm just not that good. However, after you try in things, you get contaminants on the surface. Now this is an extreme picture. Usually I don't have blood squirting on them. I got that. When you get blood on zirconia, the question I have for you is that a problem? Does blood interfere, or saliva, does that interfere with your bonding to zirconia? So most of us would take this crown, or these crowns right here, and we would just squirt them with our water and air coming out of our air water syringe, dry them, and then hand them to the assistant and say, put some cement in there, and then let's put them on the tooth. However, if we want to do good dentistry that lasts, we want to increase the chances of success, we want to get rid of the contaminants on the surface, proteins, debris, and most important, phosphates. Ruin the bond to zirconia. So MDP has phosphates in there. And that phosphate group is what actually bonds to our zirconia. That's where we get our chemical bond from. So if phosphates from the MDP can't grab a hold of the zirconia, in other words, if there's already phosphates on there taking the position where the phosphate from the MDP wants to grab onto, then it can't grab on. So in other words, we can't bond to the zirconia if there's phosphates from blood, saliva, debris on the zirconia. So rinsing them off will not give you the maximum in adhesion. Yeah, you can rinse off some of them, I'm sure, but we want to remove them. So you could just rinse, but you're going to compromise the bond to zirconia. Your MDP is not going to be as effective. You could use air abrasion. We already talked about 50 micron aluminum oxide. You certainly, after you try it in, could rinse it, dry it, air abrade, rinse. Now you have a surface that's pretty good for priming. Or better yet, easier, less messy, better long-lasting effect is to use a cleaner. One of the cleaners that we use is Zirclean. Now you've all heard of Ivoclean from Ivoclar. We've been using Zirclean for quite some time now. It's more cost-effective, and it's really an excellent product. Try it in after you do all your preps. Excuse me, after you do all your, you move your temporaries, clean your teeth, and we'll go over that in a second. We're going to use Zirclean on the restorations. My assistant puts it in there, smears it around with a microbrush, and then we rinse it off after about 20 seconds dry. And then we use a self-adhesive dual-cure resin cement, regenerative cement, that has MDP in it. Exactly, that's exactly where we're going. Now, the MDP, the phosphates from the MDP can actually grab a hold of what it needs to grab a hold of on the zirconia to make that chemical bond. So we've provided an environment where we can actually get a maximum performance of the MDP. If you're going to use a zirconia primer or something that you think is bonding to the zirconia, and you leave phosphates all over the surface, like from blood and somewhat from saliva, clavicular leakage, all that stuff, then you're compromising your bond with the zirconia. Again, we went over the list of things that's most commonly mentioned by dentists. Again, restorations falling out is a common problem in dentistry. Now, we've all had it happen to us for whatever reason. However, we want to reduce the chances that happen. And when we talk about a blended zirconia, you see that at the gum line, that there is a more opaque surface than there is at the gingival half. So there are blended zirconias on the market. This is an Ivoclar product. Again, so I'm just saying that that is an option for you today without layering. Why would we stay away from layering? Well, just to increase the strength, and we can get aesthetics that are just awful close. So let's do another case similar to that. This is a functional case. Again, this is a bite opening case. I won't go over that right now. On the upper, here we are doing some measuring and some gingival recontouring. Here is after 3 weeks or so in a temporary. Look at the swelling of the gums. Just, oh, not good. Not good. Probably my temporary, though. Here's our Zircad Prime, which is one of those materials. It's a blended material. The lab just puts a little stain on there. If they layer it, they can put a little bit of layering porcelain at the incisal half or so, but you don't really need that. And just a little stain on the surface, or what we call infiltration. Again, I'll leave that for another lecture, another time. I talked about preparing the zirconia surface for bonding using a cleaner. However, what about the teeth? So we want to bond to the zirconia, but we also want to bond to the tooth, obviously. So with our teeth, we want to clean the surface. We have to numb the patient if we're going to do this part, right? Because we would maybe send the patient out of the chair. Now, some of your patients, or some of you just don't care, well, whatever. But a lot of us who are into Google reviews these days, we just want to be nice to people. And so, because that's how we get our reviews. But regardless, if we numb the patient, we can wipe them with a 2% chlorhexidine. It's cavity cleanser. And we put a couple drops on that 2x2. And sometimes we do cement these without numbing the patient. We're not going to rinse and dry the tooth. We're going to wipe them with a 2x2 with 2% chlorhexidine. We're going to blot dry with a dry 2x2, unfilled gauze, cement with Theracem, and then clean up and ready to go. So again, pretty easy. Again, this was a functional case, opening bite, stuff like that. But anyway, if the preps are good and we want maximum performance, we want to clean the zirconia and treat the teeth right. All right, so 2020 has been quite a year. I told you about my surgery in my hands. I have to tell you about middle of July, a couple weeks after my surgery, I was doing a webinar, just like I'm doing tonight for you. Now, my favorite snack is an apple. Check it out. And I slice it with a slicer, and I put some reduced fat Jif on it. It's my favorite snack. I do it almost every single night before bed. So here is my snack, and I shove that in my mouth. And Honeycrisp apples are my favorite. So what's this? Look at that. That's our pool in the backyard. What is that? That's an apple in a pool. Now, again, I had my arms operated on. I was trying to do some work outside. Here's an apple in a pool. What's that? That is also an apple in a pool. I dropped my laptop. My hands go numb. I'm telling you. And I swear this could never happen to me. It happened to me. I tripped next to the pool. I hit my MacBook Pro on a chair, and it did a couple of somersaults and landed in the pool. My wife grabbed it real quick, but well, anyway, we'll see how the story ends. There's water all over it. I put it on a towel, and I bought me one of these iFix-It kits. I took all the screws out of the back. If you do implants, and implants are small, look at how little these screws are. These are just craziness, how little these are. I used a hairdryer at first. Yeah, I know some of you say, well, I'll put it in rice. Okay, I've done that with an iPhone that I dropped before, but in a pool, but that didn't work. So I tried power blowing this, and then I got all the components right. I never turned it on because I knew if I turned it on, it could get short. And so it's all dried, everything's ready to go. Put the screws back on. I let it set a day or so, and then I know what you're thinking. I turned it on, and what did I get? You guessed it, nothing. A black screen. But the computer was very clean, and so that's the good side. The good side is I got a new computer. So regardless, if your hands aren't working, you can't get maximum performance. However, if we really want to bond in zirconia, we want to do a really good job. We want to get the best long-term bond. Again, it's more technique sensitive. That's why we don't do it with everyday dentistry, but with compromised preps or high occlusal stress, we're going to try in our zirconia. After we try it in and everything's good to your satisfaction, we're going to clean the zirconia with Zirclean. We're going to rinse it off and dry. On the teeth, we're going to isolate the teeth. Isolation is still very, very important, of course. Rubber dam's probably the best, or some sort of retractors, an isolite. You get the point. Some of you are cotton roll and gauze people, whatever it is. We're going to isolate the teeth. We're going to clean the teeth with pumice and chlorhexidine, that 2% chlorhexidine, not a mouth rinse, not Paradex. Paradex or mouth rinses with chlorhexidine have flavoring agents and oil in them. Some of them have fluoride. We don't use prophy paste because of the fluoride in that. Just a regular flour pumice with some chlorhexidine in it. And then for maximum bond, we're going to use a universal dent bonding agent. All Bond Universals are our go-to product. That's a light cure material that we air thin, and it works with all of your dual cure resin cements. We air thin it well and light cure it. If you're opposed to light curing a bonding agent before you seat your crowns, which some of you are, you're worried that it's going to interfere with your seating. If some of you just can't get over that, I got that. I understand. We find that when you air thin All-Bond-U, after you apply it to the teeth, air thin it well until it doesn't move anymore. The film thickness is so thin that it never interferes with our seating, especially on a crown type restoration. But if you want a dual cure bonding agent that you don't have to light cure, then primer is for you. You mix a drop of each one of those bottles, massage it onto the tooth, air thin it, and then you're ready to cement. So that's the whole system there. And then cement with a dual cure resin. So in this case, because we want maximum aesthetics, maximum adhesion, we want the most polymerization we can get, the highest degree of polymerization of our cement. So that's why we're going to use dual link. All-Bond-U has a pH of 3.2. So it is a great material, whether you use selective etch, self-etch, or total etch. So the pH of the material has to be somewhat acidic, especially if you're not going to use phosphoric acid. A lot of you don't. For me, I use selective etch. If I have a fair amount of enamel, I use phosphoric acid on the enamel only, rinse it off, and then use my All-Bond-U. If I don't have much enamel, like on a crown prep, I'm not going to etch at all. I'm just going to use my All-Bond-U and air thin it well. It has 10 MDP to bond to the zirconia. It works well with all dual cure materials, so it is your universal go-to. Most importantly, and there's a lot of people who understand this stuff or can explain it better than me, I should say. I understand it somewhat. Less water content than other universal dentin bonding agents. Why is that important? Well, here's the deal. We need water in our bonding agent to get it to do its thing on dentin, because dentin, as you know, is an organic material alive with water in it. So we need water in there to do its thing with dentin. Hydrophilic. But after we air thin it and light cure it, it becomes more hydrophobic. And we need that for composite, because composite's a fairly hydrophobic material. So again, so we need both of those, and the water content matters, and the less water, the better. We need just enough water to get a great bond with dentin, which All-Bond-U does. But then again, after that, then we want it to be less water. So again, we want both. We kind of want a Dr. Jekyll and Mr. Hyde kind of thing, if you will. And we can do light cure or dual cure, whatever it is you want to do. So we do the dual cure whenever we can't get a light to it, like cementing an endodontic post or doing real opaque crowns or things like that. We use a dual cure bonding agent. But All-Bond-U, just light cure is our go-to product. It has a great bond to almost everything. You can see the zirconia in the middle there. So again, compared to other materials, just awesome material. And again, great value. So when do we want maximum performance? Because of great bonding these days of zirconia and teeth, let's look at some cases real quick where we need maximum performance. Middle-aged female, cuspid, that's a baby tooth. Baby tooth gets loose. She's got an impacted cuspid. The oral surgeon did not want to place an implant. So we're going to take this out and do a conservative zirconia type bridge. Zirconia is a wonderful material if the occlusion is good and if we are diligent with our preps. So in other words, good path of insertion. We're going to make a Maryland type bridge, a acid etch type bridge, a lingual retained bridge with wings, if you will, a Pontic with wings. We did a little grafting. That's beyond the scope of this course. We're going to do some shade matching for the lab. And what the lab's going to do is make us a zirconia frame with some layering porcelain on the cuspid. So again, zirconia frame. We got to bond the zirconia to the teeth. We want maximum adhesion in this case, and very aesthetic if we can. So again, you already know where we're going with this. You can see the preps better on a model usually because of the three-dimensional kind of the shadowing, if you will. Got some boxes on the bicuspids. We've got a box on the distal of the lateral, even though a lateral has a fairly shallow pulp. And we kept the margins on enamel wherever we can because we're going to etch that. We're going to try in our restoration. We're going to use our cleaner, our Zirclean. We're going to rinse and dry. For maximum bond, higher level of MDP, we're going to use a zirconia primer. So for those cases where we want a maximum bond to zirconia, regardless of anything, we're going to, after we try it in and clean our zirconia, we're going to put our Z Prime Plus on there and air thin it the surface will look shiny. At that point, I don't need to use a bonding agent on the zirconia or anything like that. So again, after we try it in, we clean it, rinse and dry it. We put our zirconia primer on. Now that's done, that's ready to go. Now for the teeth, we're gonna selectively etch, put our Albon U on, air thin it, light cure it, and then use our Duo Link. And then we've got a restoration that is both aesthetic and very, very durable. Again, the lab did an excellent job in this case. So again, it's partly us, partly the lab, partly the materials, but in a package that works together. So that's what we're going with. Again, zirconia framework, zirconia conservative restorations in the anterior if the occlusion's good. What I mean by occlusion good is few parafunctional habits, no worn cuspids, and nothing more than a 50% deep bites. I'll leave it at that for now. Here's another case, different case. We've got a full preparation on a molar where the patient had a crown existing already. Notice that little channel in the occlusal, that just helps with retention. There was an amalgam there. On the bicuspid, notice again, the boxes mesial and distal, preparation on enamel wherever we can. Now what I'm gonna do is have the lab do a conservative zirconia bridge. So there's my abutments and my pontic. Again, maximum adhesion in this case, no doubt about it. Again, in this case, the lab put a little bit of layering porcelain on the facial of that pontic, but nowhere else. Try it in, clean with our Zirclean, rinse, dry, Z-prime. Now on the teeth, in this case, I used a universal primer. We mix a drop of each of those and we apply it to the teeth after we've cleaned the teeth. After you apply Z-prime to the zirconia, the surface should look shiny after you've air thinned it. Again, a little bit better bond with the MDP than say, than Albon U, or than the self-adhesive dual cure resin cement. So in other words, maximum performance, the zirconia primer, we still use occasionally whenever we want that highest degree of confidence in our bond. Here's our teeth. Now let's get the teeth ready. We're going to do a little selective etch. We use 37% phosphoric acid, etch 37 from Bisco, because it has benzalkonium chloride in it. That helps reduce microbes, of course. And then we're going to put our Albon U, our primer, our dual cure primer on the cuspid and on the bicuspid and the molar. Wow, getting tired. Must be a virus. Just kidding. So here's our restoration cemented with Dual Link. So again, we get a really nice result. Margins that kind of disappear with the tooth, and a great, great long-term bond. Similarly, in this case, this is a case where we did a zirconia framework and then some veneers on the centrals and laterals. Let me show you, not a perfect case by any means. I'm very critical of my own work, of course, you can tell, as we all should be, Nothing's perfect, but we want to try. So again, she was born without that lateral on her left side. On her right side, she was born with a peg lateral. That's a composite veneer I did many years before. It's time to do a cemented bridge. I don't remember the reason an implant wasn't placed. We do implants, but that's always our first choice. But we're going to prepare a pontic site. So what do we have here? We've got 4 veneers, but the veneers are cemented, even on the pontic, to a zirconia framework. So again, we're going to truss a maximum adhesion in this case. We call that a hybrid bridge. That was shown to me by Adrian Germ, who passed a few years ago. Again, another one of my mentors, somebody I worked with for years out of Great Neck, New York, a pioneer in this kind of work. Anyway, that's a zirconia framework that we have to place on the tooth, and then we're going to bond our veneers over that. The veneer material doesn't matter too much. I believe this is lithium disilicate. That's Expasil. We just need something to control bleeding or clavicular leakage, whether you pack cord or whatever it is, or sometimes nothing. But again, we're going to do etch, bonding agent, and then we're going to cement our zirconia with Duo Link. And then on the teeth that need the veneers, which are the other 3 incisors, and then the veneer on the zirconia framework, we're going to bond those with a light cure material. We're doing that while the Duo Link starts to set. We're going to place those on there so nothing interferes with my seating. After we tried them in, of course, we're going to do our cleaning and all that. And then we're going to cement them with choice 2, which is light cure only cement, because we got infinite working time and we can control the aesthetics a little bit better, that kind of thing. So again, those are 4 veneers on top of the zirconia framework. So again, just trying to give you some ideas. 2020, what a year. So, you know, the whole world's changed. And so I take my dog to the park all the time. And he was trying to be, you know, socially conscious, you know, because he heard on TV that they protect other people. So he's wearing one for me, but he didn't know how to wear it. So he put it on there and I said, well, that's good well, I'll protect your head, but won't do much for me. So here he is in my truck. I take him walking all the time. And I tell him, hey, you need to pull that down over your nose. So he puts his paw up there and pulls it down. And he says, well, now I can't see. Well, I mean, I think he says all this stuff. I think he's talking to me, but I'm not sure. So I said, no, dude, you can't cover your eyes. You won't see where you're going. So that's from his left paw. Now here's his right paw. Well, anyway, he pulled it down, finally got it fixed up. Layered anterior zirconia. Let's do one last case here. Here's a consultation. She's got a bunch of decay all over the place. We're going to do our normal stuff, whatever it is, in a very deep preparation before we do our buildups. That's Theracal, which is what our Theracem is based off of. Theracem is our dual cure resin cement that we've been talking about for our everyday routine dentistry. And Theracem is based on Theracal, which is an Portland cement type material that releases high levels of calcium and fluoride. And then we're going to do a buildup after our all bond U, and then we're going to do our preparations. Now I prepared her other teeth. You remember all the decay, interproximal and all. She had a veneer done on that central incisor, and I just kind of want to show you what we found underneath there. A little bit of over prepping by someone. Maybe it broke. Maybe that's why the veneer was done. So I'm not judging anyone. But again, a little bit of lack of retention there, I think you'd say. So we'd much rather see the her right central than the other one, because we got a better chance of things lasting. So here's layered anterior zirconia. So anterior zirconia can be cut back and layered as well. Again, contaminants, Zirclean, we're going to rinse to get rid of the proteins and the phosphates, so our MDP can bond to zirconia. I don't care what you bond with at this point. The preps are pretty good. But if you're going to try to bond to zirconia, we want to get rid of the phosphates and contaminants. Remove the proteins and phosphates, 20 seconds, and then rinse. By the way, I should have said this in the beginning, and I'm so sorry. If you have questions, go ahead and put those in, and we'll be answering those. We have only a few minutes left, but I'm going to get to those questions in just about 1 minute. I did tell you a real important aspect to some of these cements that we want to see is that they're easy to clean up. If you have to dig and scrape and just go spend hours cleaning them up afterwards, you can't hardly remove the cement, then that's a problem. So we want a great working time with some sort of phase where we can actually knock off the cement almost in one piece, which is exactly what we do with Theracem. Easy to do. So that's all done with Theracem. We did the lower ones later. There's an implant on her upper right. So that's layered anterior zirconia cemented with Theracem. So again, depending upon the need, depending upon the patient, depending on the situation, we use different materials, but the same principle, and that is good preps, adhesion to the zirconia, and making sure that we do all we can to have a clean surface that's bondable and zirconia that is bondable as well. So I'm going to take a look and see what questions we have and all, and let's take a look. Okay, so we get asked similar questions all the time. How can we clean inside zirconia after trying in before cementation? I went over that again, a zirconia cleaner to get rid of phosphates. I remember Helio Muller, another oldie but goodie. But anyway, great material, but whatever. I don't even know if they make it anymore. For patients with anaphylactic dairy allergy, is there a Theracem contraindication? Whoa, that's beyond my pay grade. I'm going to deflect that to one of the geniuses in dentistry, Dr. Sa, or I don't know that. I haven't heard that. I just don't know that. Again, a primer for zirconia. So there's MDP in a self-adhesive dual cure resin cement, which we talked about, like Theracem. There's also a MDP in all bond universal, so we could use either one of those to bond to zirconia. And then there's a specific zirconia primer, metal primer, like Z Prime Plus, which gives you a little bit better bond, in my opinion. Can we use Theracem for veneers? If the prep is retentive, you can. However, I would rather have a material that has more control aesthetically, I guess I would say. So it depends on how opaque your veneers are and how however tender your preps are. My suggestion is to etch for veneers, total etch, and then a universal bonding agent, air thin the bonding agent well, and then cement your veneer. Thank you all very much. I just really appreciate your dedication to learning, and thank Viva Learning and BISCO for their time and support. And I wish you all the best. Stay safe and have a wonderful career in dentistry. All right. We'll see you all down the road. Thank you very much.